This episode is sponsored by Dr. Chrono by EverHealth, the #1 mobile all-in-one EHR. Built specifically for medical practices, Dr. Chrono includes an integrated feature that powers a seamless payments acceptance experience. Dr. Chrono Payments offers multiple ways for patients to pay as well as insurance credit card processing. As a Dr. Chrono customer, you can easily activate our fully integrated payment solution that will streamline your cash flow and help you get paid anytime from anywhere. Deliver the best patient experience with a fast and easy way to collect payments. Visit drchrono.com/payments. That's drchrono.com/payments to learn more about Dr. Chrono today. Is there a DPC clinician, tech vendor, or industry champion that goes above and beyond to further elevate the DPC movement? Nominate them for a DPC Innovation Award to recognize them for creating traction, embracing innovation, and demonstrating commitment to the movement. DPC Innovation Award winners will be announced and honored at this year's Hint Summit, taking place in Denver, Colorado, September 27th through 28th. Nominate a DPC innovator at summit.hint.com, plus get $50 off your Hint Summit 2024 registration with promo code MyDPCStory. Direct primary care is an innovative, alternative path to insurance-driven healthcare. Typically, a patient pays their doctor a low monthly membership and, in return, builds a lasting relationship with their doctor and has their doctor available at their fingertips. Welcome to the My DPC Story podcast, where each week you will hear the ever-so-relatable stories shared by physicians who have chosen to practice medicine in their individual communities through the direct primary care model. I'm your host, Marielle Conception, family physician, DPC owner, and former fee-for-service doctor. I hope you enjoy today's episode and come away feeling inspired about the future of patient care, direct primary care.
Direct primary care to me is direct access to my patients and knowing my patients well. I'm Dr. Amanda Dornfeld from Sage Direct Care, and this is my DPC story.
Dr. Mandy Dornfeld is a lifelong Indiana resident. After completing medical school at Stritch School of Medicine of Loyola, Chicago, Dr. Dornfeld moved to Muncie, Indiana to complete her residency training. She and her family chose to settle in Columbus immediately after her residency training, where she practiced full-spectrum family medicine for 13 years, caring for patients in the hospital, in the office, and delivering babies. In 2020, she and her family moved to Whitianga, New Zealand for an expat experience where she worked as a very rural GP doctor. Dr. Dornfeld and her husband, David, have been married for 22 years. They have 3 kids who all attended BCSC schools. Dr. Dornfeld has a passion for high-quality care for patients and their families. She is just as happy caring for newborns as she is elderly patients with complex medical and social needs. Dr. Mandy has a thriving breastfeeding medicine practice as well and is a board-certified lactation consultant, or IBCLC. Since living in New Zealand, she has a new love for hiking, called tramping in New Zealand, enjoys travel and spending time with family. She opened Sage Direct Care in 2021. It's so exciting to talk with you because we opened around the same time and you have done so well and your journey is just so rich. So for people who have not heard of your story before, I hope they listen very closely. So I want to start with this incredible journey from the United States to another country. And so you were practicing in Columbus, Indiana, and then you moved to Whitianga, New Zealand. And so for those of you who are HGTV fans, Dr. Dornfeld was actually featured on International House Hunters, specifically episode 4, season 151. And you can look that up. It's also on her accompanying blog. On that note, one of the things that you had shared was that you wanted to, work overseas. So can you please tell us about that journey and what led you to Whitianga?
Yeah, I have always been kind of a person who's wanted to travel, but I never really had the opportunity in college. I was doing all my pre-med courses and very academically minded and just never made the time for it, and just kind of always dreamed of living abroad. but I never thought it was possible as a physician because of licensing, et cetera. And then, once you kind of start your career and build your patient panel and work in a health system, you just can't imagine stopping everything and changing everything to live abroad. But when my husband and I made the decision that I would be leaving anyway to start a direct primary care practice, it kind of opened up this door to something different. And we said, you know what, if we're going to leave this job anyway and start with a new practice, this would be our golden opportunity to go live abroad. And I read about other family doctors living in New Zealand. There are other first world countries and other countries, developing countries too, where you can work, it turns out, but New Zealand is one of the friendliest probably for American physicians. And I said, you know what? You only live once. Let's go do this. So for me, it was kind of a natural kind of break before starting my practice. A lot of people thought I had to do that because of a non-compete, but my health system I did have a non-compete, but it said I couldn't work for a competing health system. It would have let me start my practice right away. So I did not do it for that reason. It kind of gave us this kind of time to decompress and think about the new practice. But more importantly, I wanted to give my kids the opportunity to live abroad. And I thought it would be a new challenge for me to live abroad and learn how to practice medicine in another country. And living in a very rural area, I think helped me brush up on skills, thinking outside the box a little bit. We did not have a lot of resources where we lived. We were 3 hours away from a major hospital. We were an hour and a half away from kind of a critical access type hospital. And our practice was really all there was for about an hour and a half around. So we managed everything we could right there.
It's just incredible. And, one of the quotes that you'd said in your interview on the House Hunters episode was, sometimes you don't make a move based on what makes sense. It's just an example of how even before you opened your doors to Sage, that you were autonomously choosing to do, this journey and to, take on all of the adventures that came with it. So I want to ask there, when you were established in New Zealand, what kind of credentials did you need, if any, to get under your belt before opening? Like, did you have to do any CME? Did you have to learn new formularies because of differences in medication? How was the transition over to being a GP there?
Yeah. So I joined a group there. So it's a rather rural practice, but it's a big group because they really care for a very large subset of patients. Whitianga is a resort community. So during their summers, which are our winters, December, January, February, the population grows from about 4,000 to 20,000. And our practice was really the only medical care there. So we functioned as the acute care, urgent care, chronic care for all of those people. And so I had their support. There were probably 6 doctors total there. And we were on call too at night. So we'd go in and see people at nighttime as well if we needed. But there was really nothing I needed to do other than all of the paperwork. They do their due diligence to be sure that you've had the training, you're board certified, you've passed your USMLEs. So there's a lot of that. Probably it took, I think I decided in June I wanted to go to New Zealand, and we were there by January. So it was pretty fast overall. Of course, that was right before the pandemic, and which is another story. But with the pandemic, things got a little bit more tricky, and now their borders are opening again. But we arrived in January. Pandemic occurred March. There was a 6-week, very strict lockdown in New Zealand. And then actually they eliminated COVID completely, which was wonderful. We lived a very free life there as far as COVID. But the drawback was the borders were essentially locked. So if we left, we wouldn't have been able to come back, and no one could come see us. And I know that probably people were feeling the same all over the world, but it was a different experience in some ways than we had originally thought we would have, because we thought we would have visitors pretty much nonstop and family would be coming to see us and things like that. So that changed things in a lot of ways. And it really informed our decisions when we had to make some decisions for one of our sons needed a surgery. And instead of going back to the US for that surgery, we actually paid cash and had it done in New Zealand because COVID was raging and we were so much safer there in New Zealand.
Wow.
So there were some interesting experiences that way as well.
And as an American who was overseas, even though you had a position there, you were employed, how was that experience paying cash for something like medical care?
Yeah. I mean, I got to see the health system from both sides. And that could probably be a podcast in itself, talking about the New Zealand socialized medicine system. Certainly it saves the people there from bankruptcy and things like that. You know, they really do a great job of chronic disease care there, but it's certainly a two-tier system. So people do wait quite a long time for specialized care, especially if you're from a rural area, which we were. So not uncommon to wait three or 4 months to see any specialist or to get an MRI or an ultrasound, things like that. And so a lot of times people will pay cash or pay out of pocket to go private is what they call it. And so it creates a two-tiered system. So that was kind of interesting to see how that worked. We were not, the New Zealand healthcare was not available to us because we weren't planning to be there for 2 years. And you have to have a 2-year visa to qualify for New Zealand public health. And so that really wasn't even an option for us. So yeah, but certainly healthcare, even when you're paying cash, is much less expensive there, much less expensive.
It's so interesting to hear that side of the story. And I appreciate you sharing a little bit about the healthcare system, because that's definitely something that I wanted to know more about. And I'm sure the audience did as well. So let me ask you, when it comes to the description of waiting 3 to 4 months, it's interesting because when you said that, I think about my community where sometimes it takes longer to be seen, for a screening colonoscopy or to see a rheumatologist, depending on what type of insurance you have. So what are some of the things that you thought about when you were, living this system every single day and also having the intentions to move back to the States and open up your own practice?
Stay with us. We'll be right back. Thank you to Spruce Health for supporting the My DPC Story podcast. The ways we communicate have changed dramatically over the past decades, but technology and tools in healthcare have not kept pace. Patients want more access and digital convenience, as well as the ability to text their care teams. Care teams are inundated with more communication and rising expectations, but are still using tools and technology stuck in prior decades. Spruce Health created a solution for the tech-forward DPC practice by creating a communication product designed to serve both the patient and the doctor through intuitive HIPAA-compliant workflows, tagging, scheduled messages, and triage templates ready for use, whether you're on your phone or in the exam room. New users get 20% off for the first 12 months of a paid plan with code MARYAL20. That's MARYAL20. So check out Spruce Health today at sprucehealth.com or check out the link in the show notes.
Yeah, well, I mean, it's really interesting there. I mean, the government really is in charge of for the most part, cost containment for healthcare. And so there are things that aren't available there that are available in the US. And, I'm not here to speak to what's better or worse. It is what it is. And I'm not critical of their system. I was blessed to work in their system, and you kind of just work within it. But, for example, while I was there, they were rolling out colon cancer screening for RDHB. So before then, they did not have a program for colon cancer screening at all. Wow. You were not even permitted to do a hemocult screen at all. It wasn't even available. And colon cancer screening, as it's being rolled out, we think will start at age 65. So it's just different too. Breast cancer screening doesn't start until age 45 there, and it ends at age 65, period. And it's done every 2 years with a mammogram. So cost containment is for the good of the public health, and it may not be the good of a specific person, but they look at what the least expensive and the best for the public health is. And it's a different perspective when you're looking at someone in front of you and you're frustrated and you want them to be able to get something specific. So, but we did what we see a lot of really horrible things, difficult things in America too, right? We see people go bankrupt here with diabetes. And so, I'm not here to speak to what's better or worse, but it's an interesting perspective for sure. But things that I did, that I specifically worked on while I was there, I took the opportunity to learn phlebotomy. I hadn't done that since medical school. So I spent quite a bit of time making sure that I understood how to do that, how to apply leads, EKG leads. I mean, we can read EKGs, but I hadn't applied EKG leads ever. So, I asked the nurses to help me with that so that when I got my EKG here, I would understand how to do that. So just things like that. And the nurses, they were lovely and they were wonderful and helped me a lot with just gaining some skills that I knew I would need.
That's great. And now that you're a, solo practitioner in your own clinic, I am sure that you're benefiting from your experience there every single day.
Absolutely. Yeah. So I do have an EKG machine. It was one of my first purchases. And so that's nice. And we have phlebotomy now in my office, and I do have an RN, but she's a lot of times doing other things. And actually I love drawing blood. I think it's kind of fun. So I'm happy to be able to provide that service in the office. Yeah.
Very cool. Now, I want to just go back into your experience in New Zealand. If you're okay with it, you mentioned in the episode how you did take a pay cut. So I'm wondering, if somebody was interested in working overseas, specifically New Zealand, what is the, salary range that someone can expect when they're working overseas in New Zealand?
Yeah. So it's important for family doctors to know there's a lot of chatter on Facebook and things about working in New Zealand. But family doctors, it's a little different as a family doctor working in New Zealand than any other type of doctor working in New Zealand. And that is because family doctors essentially in New Zealand are GPs, which everyone in New Zealand gets a GP. There is no such thing as like a primary care pediatrician or a primary care internal medicine doctor. It's all GPs. And then every other type of doctor is considered a specialist. And all specialists essentially work for the government or the DHB's systems. And so if you work for the government, you're in a union and your pay is scaled by your years of experience, et cetera, and it's set for you, and you get 6 weeks of vacation and 2 weeks of CME paid for and a lot of benefits. And quite frankly, the union and the rules are set up so that your hours are set. As a GP in New Zealand, you don't generally work for the government. There are some rare exceptions to that, but basically you work in private practices. And the way you think about it is the way I think about it is there are private practices, they're privately owned, but they have a government payer. The government payer is the only payer. And so it's kind of like an HMO So they will be then contracted to have a number of lives, and they get a number of payments, so a certain amount of payment for a number of lives that are enrolled in their practice. And you enroll with a GP, and then that is your GP that you go to. You don't go to a different GP. You're enrolled with that GP. It's kind of like an HMO would be here in the US. And so when you're working for a private practice, you don't have those government benefits because honestly, they're working on a shoestring. They are trying to see so many patients. And I mean, they don't have that benefit. And so I don't blame them, but you can't expect your lifestyle in New Zealand as a GP to be what it might be if you're any other type of specialist. So I actually thought I worked pretty hard. We worked really long days. I took call. It was actually quite difficult for me to get vacation because I lived in a resort community. And so they needed me to work when it was busy, and it's busy in the summer. It's busy at school breaks. And so I think those are things to think about for people going over there. I didn't feel like it was like, oh, this is like, this is nothing. We worked really hard, and I spent time at home doing my notes. I spent time at home reviewing labs, just like in America. And I was like, oh my gosh, it just follows you everywhere. But I enjoyed my time there. But I do think that as a GP in New Zealand or a family doctor, your experience is a lot different than as a specialist working for the government there. I didn't get any CME. I didn't get paid time off. That was all different. So you make pretty much, I'm trying to think, I think it's around $100 an hour. So like $400 a session. You work in sessions. So half day is a session in New Zealand. And that is only about $75 US per hour.
Gotcha. And how many patients were you expected to see per session?
So I usually saw about 4. So we, in our practice, we had days when, just like kind of a typical American practice, we had days when we had scheduled patients, and we had days when we kind of did urgent care, like kind of acutes. And so acutes, you just like as fast as you could, right? But scheduled, it was every 15 minutes.
Gotcha.
Yeah. And you work, 4-hour sessions.
And here's the question I don't know the answer to. Were you on an EMR or were you on paper or both?
We were on an EMR, but it was quite old. It was old. And our situation was we were so far away. So the courier would come pick up labs at like 10 and 3 p.m. And then those results would not be in until the next day, like 24 hours later. And you couldn't get labs any faster. That was as fast as you could get them. So if you really were worried about something like GI bleed or something, you had to decide, am I going to send this person over the mountain? It's a treacherous drive, over the mountain to the ER to get stat labs. So, and then if they get there and the labs are normal, you're kind of like, oh gosh, that was crummy. I'm sorry, I sent them all the way there. So it's you really have to use your clinical judgment a lot. Mm-hmm. And you kind of have to think, oh, am I going to send this person on this treacherous drive, hour-and-a-half long drive where they're kind of doing this and over a mountain? Or, are we going to be able to wait until tomorrow and make sure that everything until we get the labs back?
And one of the other things that you had mentioned in socials as well as on the House Hunters interview was that you had always envisioned then opening up your own practice. And so I know that your stay in New Zealand had a time limit to it, but I want to ask, when you had envisioned, opening your own practice, when did that seed start to grow in your medical training or medical employment here, or was it in New Zealand? And how did you learn about direct primary care specifically?
Yeah. So I left employed. So I worked only one job after residency, went straight to that employed position. I always wanted to do full spectrum family medicine. So I did inpatient, outpatient, peds, newborn, and obstetrics. About 2 years before I resigned, the hospital went to a straight hospitalist model. And so we stopped doing adults. But for all that time, kind of did everything. And about maybe 5 or 6 years before I resigned, my really good friend, Maura McLaughlin, told me, hey, I quit my job at my big hospital system where she had worked and said, I'm opening this practice and it's a DPC. And I said, it's a what? And she told me about it. I went out and visited her. So Maura and I went to medical school together. We've always been close friends. Nice. And I was really happy for her, but I kind of thought she was crazy and I didn't think it would work. But I became more disillusioned with typical employed practice. There were some changes that happened in our healthcare system that took away a lot of what I felt like was my autonomy and changed the way that I practiced. And I was just unhappy with that. I felt like I couldn't be there for my patients the way that I wanted to be. And I kind of started to think, wait a minute, what is the goal here? What's the priority here? Is the priority patients? Because it doesn't seem like the priority is patients anymore for the people that I'm working for. And I slowly began to realize I had to change where I worked. And I came to realize that DPC was the only model that would work for me. And I probably would have left sooner, but I really had to grieve giving up obstetrics. There are DPC doctors who do it, but for a number of reasons, I knew that just wouldn't work for me here at this point in my life. And so it just took a little while for me to get there emotionally. So I knew for several years that this was coming and that I'd be opening a practice. So I went to a DPC summit. My husband came with me. I met people. I took pictures, but I couldn't post them on Facebook because I didn't want people to know exactly what I was planning quite yet. But then when the time came that I was ready to resign, we decided then, here's what we'll do. We'll resign and we'll go to New Zealand for 1.5 years. And Then when we come back, we'll start the practice. And that's exactly what I did. We left January 2020, came back June of 2021, and I opened August 9th, 2021.
Stay with us. We'll be right back. Have you tried an AI scribe in your clinic? Well, I've tried so many, and I can say Heidi Health is the best AI scribe I have come across thus far. With Heidi Health, I can create unlimited customizable templates for my notes to help me truly cut down on the time I'm spending charting. Template for pediatric well child check? Done. Template for weight loss management? Done. Some of my favorite things I've built into my AI template, beyond the general soap note, are having a list of actionables for our team to take after a patient visit, having the diagnoses listed, and creating an after-visit summary for our patients. Not only have I found Heidi Health to be the most helpful, customizable AI scribe so far, it's also more affordable than most out there. So try Heidi Health today and see how you can harness the power of an AI scribe for your practice. To get an entire month of Heidi Pro free, go to the homepage of mydpcstory.com and click on the Heidi Health ad.
So many questions there. So I want to ask first, because you mentioned your husband, and one of the things that I love about house hunters is they say like, this house is this much money, this house is this much money. And there definitely was financial banter between you and your husband in that episode about, which home were you going to choose? And so I want to ask, when your husband and you were discussing about, okay, now as we're in New Zealand, I'm planning on opening Sage, what was the discussion to plan, especially financially, because your husband's a CPA, to open once you got back to the States so quickly?
Yeah. So, I will say opening your own practice is a huge risk. I mean, going to New Zealand, you could say, well, you lost so much money, but we gained so much too. Who cares about money? We were able to live. We were able to, for people who wondered, we lived on what I made in New Zealand. We didn't use our savings. We were fine. You just live a little bit more modestly, and we traveled and we did a lot of exciting, fun things. But I think you just kind of reframe your world a little bit. And you don't have Netflix, and you don't have Amazon, you don't have Target, in New Zealand. So that just takes a whole bunch of money away. But everything's a little bit different, and your priorities change a little bit. But the other thing that I need to say about a supportive partner is that he was 100% on board with me leaving a really good paying job and opening a DPC from day number one, because he knew how important it was for me to be happy and how important it was for me to be able to take care of patients the way I felt like I needed to take care of them. And it didn't matter to him if I was going to be making a third of what I was making or whatever it was. It didn't matter, because at that point, it's not about the money anymore. People survive on very little money. It'll work out. And he knew it would. So that was never a question in his mind, that's what we should do. And I should point out that I was always the main breadwinner in our family. Dave was a stay-at-home dad since my kids were babies. We have 3 children. He is a CPA, and he always worked just tax season. So he always worked part-time during tax season, so he could be home by 2:30 and get the kids from school, January through April until 2:30. But I was always the breadwinner. But it didn't scare us, because we knew that we just felt very confident and that we were making the right decision for us. So.
And when you guys, though, had the discussion that you were going to open Sage, did you guys save up even before you moved to New Zealand to open your doors? Okay.
Yeah. So that's a good question. Like, how could we come back and start this business? Because I've not done I've been blessed that I've not moonlighted. I don't have a side gig. So we knew we needed to hit the ground running and get this practice opened as soon as possible. So we landed, I think, like June 9th, and I opened August 9th, which I think about it, it's like, that's crazy. But so we did save quite a bit of money before we left, so that I'd be able to start the practice when we got home. And then of course we had to use some of that money to pay for Luke's surgery in New Zealand. That was unexpected, but you do what you do. So but my goal was to get home and get this practice started like really quickly. So when I was in New Zealand, I started posting. I'd had a Facebook page for a while, like Dr. Mandy Dornfeld, and people kind of followed me, and I'd post occasionally. And then I started increasing the posts. And then after I decided on the name of my practice, I changed the Facebook name to Sage Direct Care and introduced it that this would be my new practice. And so I already had some followers, which worked out really well. And so I kind of started generating chatter, social media chatter that way. And so people were interested. And I think that really helped that even though I'd left the community for a year and a half, or essentially almost 2 years at that point, people kind of still remembered me and my story, that I'd been away and came back, and that I was coming back. And so I found an office space in July. It wasn't exactly what I wanted, but we needed to make it happen quickly. My office space is in a strip mall, which is not what I wanted either, but it's about 1,500 square feet, way bigger than I wanted. But you know what? A lot of things worked out for the best. So my husband also decided to start his own CPA firm. Mm-hmm. So we did want space big enough that he could sublease from me, because it's just convenient to be in the same space. And the build out started kind of mid-July. Wow. I opened August 9th in a back room of that space. Like literally there was construction going everywhere, and there was like this little trail you could take, and there was like a back room that I kind of had set up, and it worked, it looked nice in there. We had an exam table that I'd bought used before I went to New Zealand. I had a little desk, I had my computer and things, and people were very patient. And I look back then, I think they must have thought they were joining this cuckoo practice. Like, I can't believe they even came and saw me there, but they did. And it took about 4 to 6 weeks for the build out. And then, so I now have 2 exam rooms, an office for my nurse, kind of a phlebotomy station, a handicap accessible bathroom, and then a really nice big open space with like a couch that patients can sit on if they're waiting, but most people don't wait. And then a little coffee station. And then we have like a little break room, and then about 500 square feet that I just wasn't sure what I was going to do with. It was just there, and it's with its own private door. And long story short, a chiropractor who I've known for 13 years, a really lovely lady, was looking to start her own private cash pay business. And after being part of a larger practice in town, and it just dovetailed really well. It was the right size for her needs, and I didn't really need the space. And so she paid for her own build out, and she's actually opening April 4th. So, and it was definitely a decision, to put someone in that space. For one thing, you're sharing your space. And by doing that, even though I'm not employing her, you are certainly saying something about the people in your space, that you endorse them. There's somewhat of an endorsement there. But I know her really, really well. And she's, I definitely chose someone that she's very much a proponent of Western medicine, vaccines. All through COVID, she, talked to people and posted on Facebook and social media talk to me about COVID vaccines and why it's important and things like that. So I felt like it was a good match for me.
That's wonderful that you found, such a collaborative environment. You're tailoring your practice and your setup to your community. So I really love that.
Yeah. So I don't know that she'll be there forever. I don't know that we'll be here forever. I'd love to buy my own space someday, but we needed to get open quickly. Yeah. And so we were able to do that.
And I love you mentioning that, because there's a lot of, especially in the people who are, exploring or pre-contemplative, there's a lot of chatter about, it's not ready yet. I'm not ready yet to open. I'm not ready yet. And I mean, you're an example of like, we got to start and it's going to happen August or not. So I definitely would say, going back to being in that place of everything is going to open on this day, whether it, the build out is perfect or not. Did you have any doubts at that time in terms of, like I got to push the date back? Because I would love for you to share this for other people listening, especially if they're, hesitating, even though really, when we look at it, you just need a stethoscope and your medical training to be able to do DPC. I mean, yes, there's some things like you need malpractice, but did you ever have any thoughts that could be helpful for other people to think about if they're in that place of, I'm hesitating, and they don't necessarily need to be?
Yeah, I think I think your points are definitely well taken for sure. I think you're exactly right. You don't need a whole lot. There are things you do need, however. I mean, like, for example, I had a kiddo, I enrolled this lovely family and told them I'll be able to help them with things and, give me a call if something happens. And literally a week after they enrolled, 1 week after I opened, their kiddo, he had a laceration on the back of his head and I needed a way to close it. And so they actually live about 45 minutes away. And, and he wasn't a girl. His hair wasn't long enough to do the little tie trick. I had suture, but it's been so hard to get lidocaine. I didn't have lidocaine. And I'm like, oh my gosh, da, 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 da. And so she'd sent me a picture. So I kind of had an idea. And so but I didn't have anything. And so this is where, just using resources. There is a private practice, peds practice in town that's not a part of the big health system. And I just called one of the pediatricians up. I said, look, would you let me borrow a Dermabond and I'll pay you back for your Dermabond? And she was very kind and let me do that. And so I was able to meet this family at the office, and it was the type of lac that, staples might have been ideal, but Dermabond was fine. It was like a 3-year-old and it was fine. And it saved this family a lot of money, and they were happy as could be. So I think there's things like that definitely will come up. And it's like, oh gosh, I'm going to need that, and now I've been open for 7 months and someone just, made an appointment to have me take staples out of a laceration. I'm like, I don't have a staple remover. So I had to get on and, have a staple remover set, but at least I had some warning so I could get it here within 24 hours. And there's things like that do come up, but usually, it would have been okay if I told that patient, I'm sorry, you're going to have to go to urgent care, but I wanted to try to do what I could for them, So I think kind of using your resources when you can.
Yeah, no, and I feel those words to my bones because, I think about what Dr. John Jacobson said. He doesn't necessarily practice what he preaches. And so I think back on my own journey, being a mobile practice, starting out, I've definitely done procedures in people's homes, but when I'm like, oh my gosh, I don't like the feeling of not having something. So I really, tried to pare down what I needed. But I mean, even opening, I had purchased things from Anda because I was like, I don't want to be caught without things like suture and things like Dermabond. So I really appreciate you sharing, that experience with that family and what you were able to do because of how you were resourceful.
Mm-hmm. Yeah. And so I just think, families understand too, and you kind of make the best of it, but we won't always have everything we need. That, I didn't always in fee for service either. So I think you have to remember that. And I think that families really are appreciative of what we do for them. And that brings up another point. I decided to go ahead and have texting service and I use Spruce. And, I find that patients really appreciate that. And I kind of decide when to write them back and when not to write them back, but I have patients text me all the time and they know that that's kind of okay because I feel like that's kind of when it works for their life. Mm-hmm. And so I know there's a lot of discussion on Facebook about, when should patients text you or are they allowed to text you? And it's like, who am I to say when they're, I don't know when they're awake or when maybe they just got home from work. And so I try to think of it from their perspective too, like they just thought of it. I can't, that's not their fault. Now I'll make the decision about when it's appropriate to write them back, but I think that they really appreciate having that as an option. So for me in my practice, that's worked out well.
That's great. And with having 3 kids, with having your practice be more than half full by the time of this interview, it's really great that you talk about boundaries because boundaries are definitely something that sometimes we don't necessarily know what we want those boundaries to be until we experience something where we're like, ooh, don't want to do that again. So, and then, you and I are very similar in not only opening date, but also technology. You and I are both on Spruce and Serbo. So how do you, in terms of using the platform with Serbo as well as Spruce, how do you combine those two to work well for your patients?
Well, I probably am not as technologically smart as you are, because I know that you really know a lot about the Serbo and all of the amazing things it can do. But what I just literally will open Spruce on my desktop, and I will, if there's a conversation that needs to be documented into Servo, I will copy and paste it into an encounter note, and I'll just label it text conversation. And then if I have made a plan as a result of that text conversation, I'll literally just write assessment and plan starting blah, blah, blah. And then that's it. But it's actually really easy to just copy and paste in your on your desktop. So I do not copy and paste every single text conversation. Most are just not significant, but anything that's significant enough that we're actually discussing something medical, I will. I really love it. And I did choose to hire, I got to about 100 patients, and I really was feeling I needed some help. I don't know how people do it with a micro practice or a practice without any help, but I was feeling like I needed some help. And so I chose to hire an RN, and it was a fantastic decision. I always knew I wanted an RN. I wanted someone who had that extra medical knowledge and was licensed. I am an only provider practice. And so if I'm not here that day, I can call her and say, look, someone's coming in. I want you to do these vitals and tell me what they are. Or I want you to, they need their they need a Rocephin shot. I know, I already decided. And because if I'm not in the building, it's okay, And so I feel like she also has 20 years of pediatrics experience. So she is really great at giving advice and triaging if I'm seeing patients, and she's, manning the phone. But it's so wonderful with Spruce that we both get the text messages. I mean, I think that's really great. We both really like Spruce. So it's been good. And so my RN also is basically my practice manager too. She kind of does like social media, practice management, and then kind of RN stuff.
Talking about your RN in terms of employment, does she work as a W-2? Is she a 1099?
What is she? So my husband's a CPA. So she set this up. She's a 1099, I believe. Yeah.
Gotcha. So I love that you mentioned that as well, because, people think of a 1099 as, like gig work for tech things commonly, but a 1099 for somebody who is an RN is definitely a way to start out if you are not sure if a person's going to be a good fit, or if you're financially just starting out and don't necessarily have the plans for a full W-2. So I love that. And how did you end up finding your RN?
I actually had about 6 or 7 people reach out to me after I opened and say, if you need someone, I'd really like to interview for the job. So people just who kind of knew of me in the community or knew me or have worked with me. And she was one of them. So I didn't know her well, but she's kind of a friend who I knew of. And she's kind of just perfect for the job. So yeah, I was very lucky, because right now it's really kind of hard to find people to work in the office. But I do think, finding an MA might have been more difficult for me. But for me, it felt like an RN was a better fit for the job description. So yeah, it worked out really well.
Perfect. Now I want to focus on your growth, because like I just mentioned, you're over halfway full. Your goal, to my knowledge, is 350 patients, which is amazing, because I just learned of a doctor in Northern California who works for a corporate system taking care of 4,000 patients. I want to highlight the wins that you've had in your DPC, specifically with growth. So by 6 months, you had onboarded over 200 patients, ages 0 to 85. And you had welcomed your RN to your practice. So I want to ask about, going back to August, you were opening, you had some chatter on Facebook, like you mentioned. How were the opening days in your practice in terms of how many people were pre-enrolled, or did you even have pre-enrollment? And how was getting patients in from being scheduled to physically being seen in your practice?
Yeah, it's kind of actually hard to remember now, but I think I had about 30 pre-enrolled, because there were a lot of people who said, oh, yes, I want to sign up. But then they didn't really understand what DPC was, right? So you need to explain. I mean, it's still a relatively new model here in this part of the country. There is another DPC doctor here in town. But again, I don't feel like it's still a well-known model here at all. And so like people say, people either get it or they don't. And the ones who get it, they're like, oh, no problem. Great. And the ones who don't are like, what? We literally had someone, Megan, my nurse, called someone back. We were making a home visit together, and I was driving, and she called someone back, and I heard her on the phone, and she was talking to him and explaining it. And she said, and she said, well, yeah, here's the price and it's monthly. And the lady said, and the lady, we could hear her whisper to her husband, that's crazy. It's like, clearly it wasn't for her, and that's fine. But so there were quite a few people who at first thought they might be interested, but then just the model wasn't a good fit for them. So I think I had 30 true people enrolled before I opened my doors. And my growth has been just about a tiny bit over an average of over one person a day enrollment since I opened. And getting them in, I remember those first couple of days, I think I maybe just scheduled maybe even 4 a day or something. And I just felt like I was going to drop dead at the end of the day because there's just so much, learning a new EMR is definitely challenging. And then you're the only one putting the specialists in, loading the radiology plays, faxing to get, how do I fax it? Well, wait a minute, I want to add a cover sheet. So all those little things you just don't think about, you're doing all of the administrative tasks. You need to get records, that fax didn't go through. I need to figure out why. And so it just took a lot of time to become efficient. But since then, I have really done essentially almost no advertising. I did participate in the community the newspaper has like a contest for best doctor, best of everything. And it costs $350 to participate in that if you put your picture, I think, in it. And so I did that. And I also did a ribbon cutting with the Chamber of Commerce. And I think you pay $350 for that because there is an ad of the ribbon cutting. And those are the only 2 paid advertising I've done.
That's incredible. And in terms of, adding one patient a day, I definitely would say, that is hard work. So congratulations on that. But when you were seeing this amazing growth, what were people saying as their lead source? What were people saying like, oh, I heard about it from so-and-so other person who's already joined your practice? Or how did your practice grow so quickly without, investing so much in advertising?
Yeah. I mean, word of mouth is huge for sure. I mean, basically that is it. That's all it is for me is word of mouth. But I think there's like a mommy Facebook group and I'm in it, but mostly just to kind of be stalking. I try not to comment. And I do see that my lovely patients are quick to recommend me, which has been very kind of them. I think it really helped that I was well known in the community before and probably had a patient panel of around 2,000 patients. And I also delivered babies before. So there were patients who would kind of come and go as obstetric patients as well. I have a few families that are health share type families. And it seems that some of them are kind of in the homeschool community health share, and they all that kind of goes together for whatever reason. And it seems like they will recommend to each other. So I think that, if they're happy, I guess they tell other people. And that's what we want to do is keep people happy.
Amazing. And because they love you in your practice. So that is incredible.
It is a different model. So we really want to treat people well. And I think it's just high personalization. And I think that most DPC doctors would say the same. And I will say also, I think my nurse, Megan, has really been a huge part of my success. I mean, she gets it. She gets DPC. She gets what Sage Direct cares about. She gets our values. And she is an extension of me and our brand. And so when I'm not able to reach out to a patient, I see her doing that on text or, by phone calls and doing what I would want to be doing if I had the time. And patients adore her. And she is just an extension of the brand. And she really takes good care of people.
I love that, the extension of the brand, because at the end of the day, you're working as a cohesive clinic and you are the lead person. You are the person who's on the website. When, people see your photo, you are the doctor. And so it's incredibly important to have anybody who's working with you really understand the model. It makes a difference because when you talk about the word of mouth, any interaction with your clinic, whether it be on social media or whether it be talking with somebody on the phone or a virtual assistant, you can really benefit from somebody, like you said, who really understands what direct primary care is and who is, a cheerleader for the movement.
Yeah. Yeah. So I think that, having the right person working with you is really a huge part of DPC. I think you could also have the wrong person and it would be I remember when I worked in employed practice, there was someone who worked at our front desk who was super unhappy and not nice. And you think, okay, this is someone who greets people the first person who greets people when they come in, and they're not a nice person. They aren't kind. So that is it's a lesson, you need to have the very best, kindest person right there. And so, customer service is a big part of what we do.
Yes. And at the end of the day, like many people have said, we are a business. This is a business model, but we are choosing to, run our desire to care for others under this business model. And so it matters when we're taking care of patients, and it matters when we're taking care of patients when finances are involved, especially. Right. I want to ask about your pricing, because I actually I took a screenshot of your pricing and put it on your accompanying blog so people can see it, as well as on your website. But I loved how you came up with your pricing. And so I want to go back to the fact that, you have an excellent resource when it comes to finances and financial planning. How did you develop your price point, and have you changed it over time?
Yeah, so my pricing is kind of unusual for DPC. I mean, anyone listening knows typically DPC is age tier-based. Mine, I felt like the complexity of the patient really isn't dependent upon the age. And pediatricians who do DPC, I'm sure will tell you that too. And I feel that I pride myself in really taking good care of children too, and spending a lot of time with kids. And sometimes kids are very complex. I have some medically complex children in my practice, and I enjoy that. And even if they're not medically complex, the parents can sure take a lot of time. So I don't really know that we can say, well, kids are inexpensive and older people are expensive. I feel like a patient is. On the other hand, I wanted to do something for larger families to kind of give them a break, because I just feel like those families, that would be hard for them to access DPC care if they had to if they were burdened with that full cost for when they have, more than 3 or 4 kids. So I also wanted to keep it simple, because I was imagining trying to remember, well, when they change age tiers, and then you kind of have this awkward conversation, and it just seemed difficult to me. So I just wanted to keep it simple. So the first family member is $100. The second is $75. The third is $50. The fourth is $25. And I cap at $250 per family per month. Period. The enrollment fee is $75 for the first family member and $75 for the second family member, and it's capped at $150 per family. Period. So part of it is just my simplicity it's too complex if it's anything else. Part of it is also, I think they need to understand that part of it is a buy-in to this model, and they need to understand that I want people who are committed to a long-term relationship, and understanding, that they're really getting a high level of care too.
Your patient number has definitely shown that people understand and value the model in your community. So I think that's wonderful. Let me ask you there, just in terms of your community, because you were working in a fee-for-service model for so long and then opened up your DPC after you returned from New Zealand. Can you share a little bit about your community in terms of, who are the typical people that join your practice? What's the average income in your area that people are able to buy into this model and afford this model?
Yeah. So Columbus is a community of Columbus proper is about 45,000. Larger Columbus is 65,000. It's a small city, but there's quite a bit of rural around it, farming community around it. We are the worldwide headquarters of Cummins Engine Company, which is a large diesel engine company. It's a Fortune 500 company. So there are quite a bit of engineers here. So my practice at this point, I do have quite a few patients with traditional insurance, Cummins patients, et cetera. I opted out of Medicare from the very first day. And so I have probably about 10% of my patients are Medicare patients. I have probably about 10% of my patients have no insurance whatsoever, not even health share, nothing. And, I can encourage them, but at least they're getting some care. And these are people with really significant chronic diseases. I saw a gentleman in my practice this week with no insurance whatsoever. He's been using his old CPAP, which is great for sleep apnea, but his blood pressure when he walked in was 180/120. And I was really glad to be able to take care of him. $100 a month is a great deal. And so, but basically his employer had said, you can't come back to work until, you get some of these things taken care of because it's unsafe. So I think honestly, that's a good deal. And then I actually have a handful of patients who have Medicaid. We do have a status in Indiana of an ordering, prescribing, referring status for Medicaid. So I can order, prescribe, refer. And they have chosen to come here for a number of reasons. I think being a little bit fed up with the system. I think with the pandemic, the pediatricians in our community kind of changed access, and no fault of their own, but, changed the way that patients can access and get appointments. So it made it quite difficult at times as a working parent to be able to get in, for appointments that work with their schedule. I have one kiddo who's significantly medically complex and has Medicaid because of that. And mom felt like it was just, they weren't getting the time they needed, in a 15-minute appointment. So, I can help them out. But I think, and then a lot of families, I have several families with health shares and and a lot of big families with health shares. So it's a good deal if you have 6 kids, 8 kids, and you're paying $250 a month for primary care.
Absolutely. I can imagine what a family of 6 would have to face had they not had access to your practice in terms of avoidance to go to the doctor as a cost, as well as, just copays that might add up for every well-child visit or every time somebody gets sick. And then delays in care definitely add up if you have to go to the urgent care. So yeah, it's just incredible. And no, let me ask, in terms of, because you're in your first year, this is based off of some dialogue that I've seen with regards to overwhelm when it comes to growth of the practice, when it comes to the types of patients that you're taking care of, when it comes to boundaries, any and all of the above, when it comes to, feeling the sense of overwhelm as a DPC physician and owner. So I want to ask, in terms of your time in DPC, have you experienced overwhelm, and how did that overwhelm look to you, and how did you get through those times?
Yeah, I definitely feel a little overwhelmed at times. And I have considered pausing new enrollments, but I really don't think I should, because I think it's hard to get that momentum going again, because then it's like the word gets out that Dr. Dornfeld's not taking new patients. So I think that, as long as we can kind of keep on keeping on, I'd like to just get full and then have a waiting list. And I actually think things will settle down quite a bit, because I don't know what other DPC doctors have found, but I find when onboarding a new patient, it seems like it takes quite a few, maybe a few appointments before they're kind of settled in. Maybe there's some acute issues we need to deal with, or maybe some chronic issues that we're not taken care of for a long time. And so there's just a lot of attention that we need to, give to that person. And so it's just a lot. So I'm hopeful that, and that's kind of what I keep telling myself, that once I get to kind of a sustainable point where we aren't growing, that everyone will kind of be settled in, and I can catch my breath a little bit. So for sure that has crossed my mind. I could not do it without a nurse, kind of a person to bounce ideas off of. So for me, that was huge. It's also a gift to myself, because clearly I pay her, and, I could make more, I guess, without her. But for me, that was definitely worth every penny. She's really, really helpful to me. And then my husband's, he doesn't work for us per se, but he is in the same building as he subleases, but he kind of manages kind of the behind the scenes, like if a credit card doesn't go through, then he'll kind of be the person who calls the patient and says, oh, we noticed your credit card didn't go through. Do we need to change the credit card or something? So it's kind of nice that, like, as the clinical person, I don't have to do that, because I don't want to do that really. And so it's really great that he's able to do that, kind of take on that role.
Gotcha. And how about in terms of your schedule? Like you mentioned how you'll ask for, records to be sent to you. Do you have time in your schedule that you've blocked for administrative tasks or doing the financials? How does your schedule work?
Yeah. So I don't schedule patients on Thursdays. I will see people acutely, like if, they call in and they're sick or whatever. So like this past Thursday, I saw 2 people, but, so that'll be my day to do things at home, but I'll also, come in and do things around the office or do administrative things. Or Megan and I will meet and talk about, upcoming social media posts, or we have like a little newsletter we do every 3 months. We talk about that. So that's kind of my day for things like that. But I would say, honestly, I still work so much less than when I was in fee for service, and on call all the time. And it's just so many notes and messages. And it's just, my life is so much fuller now. Really. It's just much better.
I love it. And one of the things that I loved reading about on your website, and I'd love to have the audience hear more about, is you are also an IBCLC. And so can you please share about the breastfeeding medicine arm of your practice?
Yeah, so I do have, Sage is Sage Direct Care and Breastfeeding Medicine. And I was doing breastfeeding medicine. I've actually been an IBCLC for 10 years. So I've been doing breastfeeding medicine for about 10 years. And I'm a member of the Academy of Breastfeeding Medicine. And in private practice, I started that in putting that into my practice, and to the point where I was seeing consults from outside the healthcare system. People were coming to see me for breastfeeding medicine consults. And I think honestly, it probably frustrated the healthcare system somewhat because I did not have enough time for my own patients, but it was something I loved and I felt like there's a need for it. So I have 2 exam rooms, and one reason is that one is set up for breastfeeding medicine. I can see other people there. I could, so it's nice to have a second room as an option. In DPC, you don't really need more than one, but it is nice, to have a second room. If like during the height of COVID here, if someone came in accidentally who had COVID, we could kind of like close the room off and then have the other room. But so I use the other one for breastfeeding medicine generally. And it's so nice. I have a recliner and I have the baby scale and everything I need in there. And so for that side, if you're a member of the practice, I figure you get everything I have. So if you're a member of the practice and you need breastfeeding medicine help or breastfeeding help, there's no extra charge, because I kind of figure how can I delineate that? Wait a minute. Well, I'm helping you with your baby and all of a sudden now I have to charge you. It's just, I can't do that. So, but if you come to me and you're not a member of our practice, that's the one time I'll see non-members. And so it's kind of an a la carte fee. And I block an hour and a half for a full consultation with the mom and the baby. And, we can address things like poor weight gain or pain, tongue tie, all kinds of things. And generally I do a full assessment of mom and baby, watch the baby nurse, do a pre and post weight, and then kind of develop a whole feeding plan. And what I tell the mom, and then I do invite them to Spruce, and I tell the mom, includes 2 weeks of follow-up. And I'm sure if she called me later, I'd probably answer her questions too. But generally it seems like that works out. So I don't know if that's the right, answer or not for that, but it seems to be working. So I have not really promoted that because honestly, I've been so busy with my DPC patients. So the patients I've seen have just kind of come because they've heard. So I do give them Serbo allows you to print out a receipt with like the CPT code and the ICD-9 code and everything. And I do give them that if they want to try to submit that to their insurance. Obviously on the DPC side, we don't do that, but for that side I do. And I do use lactation codes, and some patients have been reimbursed, but I warn them I can't guarantee that. Patients can also use their HSA if they want. So that's kind of how that works. And at some point, I probably will want to promote that a little bit more. I probably see, 3 a month right now, but right now it's just 3 months fine. But at some point, I'll probably grow that some more.
And when you talk about growing that some more in your future and going back to the goal of reaching 350 for your practice, I want to ask, how did you come up with that number as your goal?
Honestly, I kind of looked at, I knew I wanted to have the breastfeeding medicine practice as well. And I wanted to be able to have time to be able to do breastfeeding medicine. So that was one reason why it's not like $450. And then I also kind of looked at what I expect my per member per month to be. And I really wasn't sure what it would be. You don't really know like what your average will be, but my average seems to be about $75 per member per month. And then you kind of just look at your expenses and start subtracting them out. And, my nurse is my most expensive expense. People always are. And then, your rent and everything else. And then just look at, am I going to be able to, what do I need my income to be? And that's kind of how I came up with that number. And so, it could change. It was a shot in the dark. I didn't know. When I was in New Zealand, kind of coming up with this, there were so many days I just thought, will anyone even come? Will anyone sign up? I don't know. I didn't know.
I absolutely love you sharing that, because it is a leap of faith that we all take, but that is definitely grounded in the idea that we value autonomy, we value quality patient care. And so I love that you have the time to run your practice the way you wish to run it, and your practice is thriving. So I want to ask in closing, when you look back on your experience in fee-for-service, your experience in New Zealand, your experience so far in your DPC, why should people look into this model?
I think this model, I can't even say it in a couple sentences. I really think it's going to save primary care. I really am a firm believer in that. If you look at what's happening with the loss of autonomy and moral injury and burnout in the traditional model, I think, that those doctors are just really, the loss of autonomy caring for our patients is really a huge loss for us. And I think that this model is really important to be able to save primary care. I also think that it will save money, healthcare dollars. We think about, patients have to pay money. But if you look at the healthcare dollars overall, I really think it saves money in the big pie, the big picture. And we need to start looking at how to cut down on wasted dollars in the healthcare system. And I think that, we need to start looking at unique, novel ways to do that. And I think DPC is the way to go. I just think this is it.
And for those people who have taken your words to heart, in terms of the first steps, what would be, the first steps that you would recommend somebody take if they're exploring DPC and they're just really learning about what this movement is and who is doing it?
I would go to one of the DPC conferences. So there's Nuts and Bolts, there's the HINT conference, there's the DPC Summit. I would read one of the several DPC books out there. I don't want to name them all or I'll forget them, but Paul Thomas has a great book, and Spark DPC has a book, but there are several. There's lots of books out there. And then obviously this DPC podcast is a fantastic resource. And then lastly, reach out to one of the many, many DPC doctors. Most of us are really passionate and ready to help and mentor anyone who wants to do it. That's what happened to me. Lots of people, told me I could do it after I was like, I don't know if I can. And, they said, yes, you can. And here's how. I think it's believing in yourself. Most of us weren't trained in business. So I think that's a huge leap. I think it's really unfortunate that, we don't get that training in medical school. But the neat thing about DPC is it's a pretty simple model, really, with the billing. It makes it very, very simple. So you are your best. So you are the resource. And I think you have to remember that you really hold the power there. So I think we're so used to feeling like little pawns and, we have to do what people say, but, you have the education. So you can start your own practice and be your own boss and take care of patients.
With those words of empowerment, thank you so much, Dr. Dornfeld, for joining us today.
Thank you for having me.
Next week, look forward to hearing from Dr. Clodagh Ryan of Cara Direct Care in LaGrange, Illinois. Coming soon, we're putting together a special episode where we're needing listener participation. Head on over to the contact page at mydpcstory.com and leave a voicemail on our SpeakPipe with your name, clinic, how many years you've been in the DPC space, and your best advice for those looking into DPC as an option for their future. If you've enjoyed the podcast and you haven't yet done so, subscribe today and share the episode with a physician you may know who needs to hear all these DPC stories. Please leave a 5-star review on Apple Podcasts and on Spotify now as well, as it helps others to find this podcast too. Lastly, be sure to follow us on social media. If you're wanting to continue learning more about DPC, check out dpcnews.com. Until next week, this is Marielle Concepcion.